Hi, I'm Bill Wierda from MD Anderson Cancer Center in Houston, Texas, and I'm here with my friend and colleague, Dr. Lydia Scarfo from the San Raffaele Scientific Institute in Milan, Italy. And we're at the iwCLL 2019 meeting, and we're going to have a discussion about new findings and things of interest in terms of clinical management of patients with CLL, particularly paying attention to minimal residual disease and new treatment endpoints for patients with CLL. So good morning, Lydia, and welcome.
Good morning, Bill. Thank you for having me today. It's a pleasure to attend this meeting. It was a very interesting meeting so far. And I think we have been learning a lot about MRD and new drugs combination aiming at achieving deep responses in our CLL patients.
So tell me a little bit about how what your view is today of minimal residual disease and how it's useful. Maybe we'll start first with your clinical trial design and including it as an endpoint in your clinical trials, and then we'll talk about standards of care.
Yeah, sure. Both regulatory authorities, EMA and FDA, actually suggested to use MRD as intermediate endpoint in designing clinical trials. And this is a very relevant achievement because with the improvement of progression-free survival and overall survival with novel agents in our patients, we may need a long period of time to understand if further treatment is leading to better results. So having this intermediate endpoint that correlates with progression-free survival and overall survival, I think it's a very worth tool to be used in the clinical trial design for our patient with CLL.
So are you routinely including it in your clinical trial endpoints that you're designing today?
We recently designed, and I'm presenting the results on the last day of this meeting, the initial results, a clinical trial based on MRD-driven approach. And it's based on treatment intensification in patients who have detectable MRD after a defined period of treatment with venetoclax. So I would say this is a very useful tool in designing clinical trials. It's not yet validated in clinical practice, so I'm not using MRD to define the treatment plan for my patient in routine clinical practice, but definitely it's worth investigating in clinical trials.
So it's intriguing. So that for me, in my view, there's sort of two components to MRD in assessing clinical trial outcomes. One is looking at the end of treatment and the MRD negative rates, particularly in a phase 2 or phase 3 randomized trial, and that reflecting what we expect to see with progression-free survival. The other component is what you were talking about, and that is an MRD-driven endpoint and adjusting treatment. And we're just now working towards clinical trials that get at that endpoint, and it's very important. And I think with time, hopefully, we will be able to integrate that into our treatment strategies, MRD as an endpoint, and working towards achieving an undetectable.
I totally agree with you because we now have combinations that are administered for fixed duration. So we have to understand if all patients should receive the same duration of treatment. Actually, it could be that MRD can be used as a tool to intensify treatment or reduce the treatment duration if needed.
In terms of methodologies, you're using what methodology to look at MRD these days?
I think that the methodology that was most widely available and was standardized by a cooperative effort of Eric and Australian and US colleagues is the 6-color flow MRD evaluation. I know you have more experience also with novel technique like NGS technique so in my opinion still need to be validated. Is that correct?
So I would agree with that. We've routinely used flow cytometry. I think one of the critical aspects is that to have a standardized assay, and Eric has done a great job at providing guidance and developing a standardized methodology for evaluating by flow cytometry. Sensitivity is probably the most key aspect, assuring that we have a sensitivity of 10 to the minus fourth, which has been set as a standard. We are working on newer methodologies. We have been working with adaptive, with an NGS-based platform. And the sensitivity is a bit higher with the NGS-based method. We can get up to 10 to the minus sixth sensitivity, and we're collecting data, and we'll have an idea about is it important to achieve a higher sensitivity for the assay? What do we need to use in our trials and in terms of endpoints? Just back to the clinical application, a routine practice, I would agree with what you said about it's not yet ready for prime time in terms of routine clinical use. Although there is some emerging data with regard to venetoclax-based therapy, the Murano trial provided a little bit of insight, and I'm expecting to see some update from that at ASH with regard to who are the patients that are likely to progress early after they discontinue venetoclax. And my impression was that if you can detect MRD, those are patients who are potentially more likely to progress. And so I'm starting to use it a little bit in terms of testing patients at the end of a fixed duration of venetoclax-based therapy, with the thought that I may think about monitoring those patients more closely in a treatment-free interval, or even continuing them on monotherapy with venetoclax if they have a high level of residual disease. There's been also some discussion this morning about minimal residual disease and a cutoff, and if I've heard a couple people today mention that if patients have more than 1%, that's really residual disease, not minimal residual disease, and they behave more like patients in partial remission. And so working towards a level at least lower than 1% when we have discussions about minimal residual disease, I think is important.
I totally agree, and what I think is that we could also consider MRD monitoring to understand if it's time to retreat the patient, but using the same drug or combination we used in the previous line of treatment, because actually it's not exactly as they have lost their response to treatment. We just stop treatment and then we can restart. And in this regard, I think there are some experiences with venetoclax, as you mentioned, when it was combined to rituximab, some patients getting very deep responses could interrupt treatment and then were retreated with venetoclax and obtain again a response upon retreatment with the same drug.
I wonder if we could maybe shift gears a little bit to treatment. Are you using chemoimmunotherapy-based treatment in your clinical trials now, or have you transitioned into a chemoimmunotherapy-free?
We have definitely moved to a chemo-free approach. Actually, I would say that also in clinical practice there is a very small room for chemoimmunotherapy nowadays. We are currently using chemoimmunotherapy only in first line in young patients with favorable prognostic feature like mutated immunoglobulin genes and devoid of TP53 aberrations, because your studies and the German CLL study group already proved that some of these patients can be progression-free more than 10 years after completing treatment. But besides this category of patients, we are very focused on a chemo-free approach, and we are also designing clinical trials based on a chemo-free approach at our site.
I think we've had a revolution of therapy in CLL over the last 5 to 10 years with a small molecule inhibitor based therapy. I think venetoclax has really brought in to the discussion minimal residual disease because it is so potent at eliminating disease. And we've been very excited about our combinations, BCL2 plus BTK inhibitor combinations. We're seeing very deep remissions with those combinations with a very good toxicity profile and a very well-tolerated regimens. What combination trials are you interested in and thinking about today?
I'm very interested, as you mentioned, on the combination of BCL2 and BTK inhibitors, because starting from preclinical data confirming a synergistic mechanism for these two classes of drugs, actually also initial clinical data confirm that they are very effective, and your group recently published impressive results in first line with the combination of ibrutinib and venetoclax, but also very very positive results were obtained in the relapse refractory setting, and the Clarity study was presented at ASH, and I think an update will be presented during this meeting. And it seems that the toxicity profile of this combination is not leading to any unexpected toxicities, so it seems quite tolerable even in older patients, as many of CLL patients are.
We're very excited about the combination. There's a couple of, it's interesting as we get these new combinations, it seems to me that we're answering questions that we can get to deep remissions, but we get more and more questions with the new regimens and more data, which is exciting. Things like, what is a reasonable fixed duration of therapy, or should we transition all of our trials into MRD-based endpoints? There's been some discussion about treatment-free interval and relapse of disease and what retreatment looks like. I think people's view is somewhat shaded by our experience with chemoimmunotherapy. With chemoimmunotherapy, we could get patients in remission. They would be in remission a specific period depending on the patient and the patient's characteristics. Their disease would relapse, and we would retreat them. Usually the response rates were lower with retreatment, and the remission durations were shorter. It'll be interesting to me to see if we make that same observation with the targeted therapies, because mechanisms of resistance are very different. And so I think one of the outstanding questions in my mind, and will be revealed in the follow-up work that we do from the trials, is what does relapse look like? What does resistance look like? What does retreatment look like in response with retreatment? So those are very interesting and exciting areas. It's going to take some time for us to provide some clarity around that. But
I totally agree with you, because we need longer follow-up to understand how durable these responses are and what are the characteristics of the disease at relapse. But I would say it's worth trying to interrupt treatment, of course, maybe based on the MRD-driven approach, in order to reduce the selective clonal pressure that is a potential mechanism of resistance over time, and also the economic burden, and also to improve, I would say, the quality of life of our patients.
I'm curious about your thoughts. You mentioned some work with chemoimmunotherapy and use of FCR-type regimens for mutated young fit patients. And our long-term follow-up with the FCR regimen showed that there was about a 50% progression-free, long-term progression-free survival for patients with a mutated V gene. Perhaps some of those patients are cured. It's 50%. That information was confirmed, or that data was confirmed by the Germans, and David Rossi has also reported on their experience. One of the things that I'm thinking about today is, with the new combinations, if we achieve an MRD negative endpoint, particularly for those patients with a mutated V gene, are we going to see the same effects? Will we see potentially see a cure fraction among those patients also? Wonder what your thoughts are on that.
I think that the young fit patients with CLL are a very difficult to treat category nowadays, because you have many options, including chemotherapy. I was very interested actually in the study you recently presented about the combination of a more potent anti-CD20 monoclonal antibodies, obinutuzumab and ibrutinib, to reduce the number of cycles of chemoimmunotherapy in patients actually who would be candidates to FCR treatment. But as we mentioned before, actually I would say we have the short follow-up nowadays. We need longer follow-up data to understand how durable is the response in this setting.
MRD has been helpful in giving some insights into that, and the regimen that you're mentioning is iwCG. I think follow-up serial MRD monitoring will be informative with regard to that trial also, and we're seeing very, very impressive results with the iwCG trial. Everybody at the end of the year of treatment who's been treated so far is MRD negative by MRD4. We've been testing also by MRD6. It's about 70% who are MRD6 negative. So I think not everybody, there will be patients likely to relapse on that trial, but it's a very potent regimen to get patients in remission. And as you mentioned, with a lower, less amount of chemoimmunotherapy with that regimen. But we're very excited. I'm excited to also see some of the larger trial results with patients with a mutated V gene, like the Captivate trial.
Yep.
I don't know if you participated in Captivate, but that trial enrolled untreated patients with a mutated V gene, and they received ibrutinib plus venetoclax, and so we will have a large amount of data from that trial, which will be very informative.
I confirm we were involved in Captivate trials, and I saw the preliminary data you presented last year, and I think the patients got a very impressive overall response rate quite early with combined treatment. And also what's interesting to note is that starting with ibrutinib first is reducing the tumor burden at the time of venetoclax initiation. So the risk of TLLs was reduced after a few months of treatment with ibrutinib. And the combination was actually well tolerated without any unexpected toxicity. I would say diarrhea and neutropenia were the most frequent adverse events occurring in that trial. And this was a MRD-driven strategy because you were randomizing patients based on MRD status to continue treatment with any of the drugs or to stop treatment. So it was a very useful trial, I would say, to understand MRD and the efficacy of novel combinations.
It'll be an informative trial. I think just to sort of summarize and give a high-level overview of what's going on today, it's very intriguing to me that when we have discussions among our colleagues, we have more phase 3 data to talk about than we ever have had. There are several options for frontline treatment, and when we discuss with our colleagues, you hear a lot of different opinions, and there are options, and people have different concepts and ideas about what the goals of care are and what their recommendation is for patients. We're seeing a little more personalized therapy than we were, but we have a lot of options, and there is a lot of diversity in terms of approaches and recommendations for first-line therapy. I think, though, most of us can agree that we're all excited about the combinations with the new small molecule inhibitors and how well they're tolerated, how deep of remissions that we can get with the combination therapy, and I think everybody is in agreement in terms of experts that work in this area and develop research and trial objectives. Everybody's interested and focused on MRD as an endpoint for our trials.
Definitely, but I think it is also a challenge to understand if all patients need to receive the most effective drugs we have, if there are diseases which will be responsive to less intensive treatment, because there are combination currently study of the most effective drug we have available, like BTK inhibitors combined with BCL2 inhibitors with anti-CD20 monoclonal antibodies. And my question is, if we are using all these very effective drugs together in first line, what are we doing at relapse?
I think that speaks back to the point that I was saying. I wouldn't anticipate that patients are necessarily refractory to treatment when they relapse. So I'm expecting to see responses with retreatment. Now, if a patient relapses very shortly after they finish their treatment, that's probably going to be a different strategy in terms of management for those patients compared to if they have a long treatment-free interval and remission. Well, thank you for your time. It's been a pleasure speaking to you.
Thank you.
And thank you for your hard work and all of the important work that you do for our patients with CLL.
Thank you for involving me. It was a pleasure to be here.